Welcome to a new medical educational video. This time the topic is going to be lung cancer. Epidemiology. Lung cancer is the third cause of oncological death, the second most common cancer and a leading cause of cancer death worldwide. The peak incidence is at 65 to 75 years old. Etiology. Tobacco smoking. Smoking is associated with the development of 80 to 90% of lung cancers. The risk of cancer is determined by the number of packs per year, quantity of cigarette packs a person smokes per day by the number of years of cigarette consumption, and there is a weaker association with lung adenocarcinoma. Occupational and environmental exposure to carcinogens, such as passive smoking, radon, and uranium, which radioactively decays into radon. Also, asbestos, occupational carcinogens like arsenic, chromium, nickel, beryllium, or silica, and last but not least, environmental air pollution that also plays a role. Family history, genetic predisposition, other risk factors like pulmonary scarring, previous radiation, pulmonary fibrosis, or chronic infections like tuberculosis or HIV. Patient presentation. The patient can present with symptoms or asymptomatic after a finding of a solitary pulmonary nodule in an imaging study for another reason. Solitary pulmonary nodule, or SPN, is a nodule of less than 3 centimeters and asymptomatic. The vast majority are benign and can go home after the finding. There are some criteria which makes them think they are benign or malignant. Benign criteria includes patients who are non-smokers, less than 35 years old, and have benign radiology. This means a nodule that doesn't double its size in 1 month, a stable nodule during 2 years, or a nodule that has benign calcifications. For example, amartoma has a popcorn-like calcification and granuloma an ox-eye one. Malignant criteria include low risk, those fulfilling 2/3 of benign criteria. Medium risk, 0 to 1 out of 3, and high risk are those with malignant radiology, with the presence of speculations, pleural tail, or corona radiata in the imaging study. SPN indications. According to the size and the risk of malignancy, there are several indications. If they are small, it means a mass less than 8 millimeters. We can classify them in low risk, intermediate risk, or high risk. Low risk and less than 5 millimeters have no indications. Low risk and 5 to 8 millimeters, we should repeat a CT in 1 year. Intermediate or high risk and less than 5 millimeters, do a CT every 3 months until the 12 months. Large masses are those with more or equal to 8 millimeters. Low risk, we will do a CT every 3 months. Intermediate risk, we will perform a biopsy puncture and a PET CT. If high risk, perform a surgical biopsy. Types of lung cancer. We can classify them into small cell lung cancer and non-small cell lung cancer. The latter can be further classified into adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Clinical features. There are several manifestations depending on the location and type of tumor. According to location, central located tumors have obstructive symptoms such as cough, expectorations, pneumonia, hemoptysis, atelectasias. They are more common in squamous cell carcinoma and small cell lung cancer. Peripheral location. They can be asymptomatic or present irritative symptoms such as dry cough and pleuritic pain. They are more common in adenocarcinoma or large cell carcinoma. Lung cancer gives a lot of constitutional symptoms too, like asthenia, weight loss, lethargy. Acropathy is another common sign of lung cancer. Squamous cell carcinoma, large cell carcinoma especially. However, the differential diagnosis of acropathy is broad. Some examples include interstitial pulmonary fibrosis, cystic fibrosis, bronchiectasis, inflammatory bowel disease, and many others, like pulmonary abscesses, mesothelioma, cirrhosis, cardiac insufficiency, or congestive heart disease. Mediasthenic symptoms. These are more common in central tumors or peripheral with large lymphadenopathies. Superior vena cava syndrome is typical for small cell lung cancer. It presents with edema and erythema of face and upper limbs. It requires urgent treatment with chemotherapy, radiotherapy, glucocorticoids, and sometimes diuretics. Pancoast tumor is a vertex tumor typical for squamous cell carcinoma. It is painful, causing subscapular and cubital pain. Horner syndrome is also typical of this type of tumor, causing ptosis, meiosis, and anhidrosis due to the disruption of the sympathetic nerve supply. Pancoast tumors require triple therapy: chemotherapy, radiotherapy, and then surgery. Dysphagia, dysphonia, and dyspnea are due to the invasion of mediastinal structures like the esophagus or the trachea. Paraneoplastic syndromes. Lung cancer is the cancer with biggest number of paraneoplastic syndromes. Squamous cell carcinoma has the production of PTH-like substance and pseudohyperparathyroidism with hypercalcemia. Adenocarcinoma, even though it's rare, it can produce an hypertrophic osteopathy in elbows, knees, and hips. Large cell cancer can produce gynecomastia. Small cell lung cancer can produce SIDH, Cushing syndrome, or Eaton-Lambert syndrome. Diagnosis. Diagnostic studies in lung cancer include CT of the thorax and abdomen. If lymphadenopathies of more than 1 cm are found, they are considered malignant. Size and invasions of structures are evaluated too. Tumor biopsy. Histology is performed. If central, the biopsy is taken by bronchoscopy. If peripheral, by CT-guided biopsy. Extension. Also evaluated in the CT of the thorax and abdomen. If a small cell lung cancer or adenocarcinoma, we also do a CT of the brain due to the high possibility of appearance of metastasis there. If a small cell lung cancer, full body CT is performed due to the possibility of presence of metastasis. If lumbar pain, we will do an MRI to check for metastasis in the vertebrae. If available, we should do PET-TAC or PET-CT. Mediastinum, evaluation of favorable prognosis for surgery. If N0, surgery, lobectomy, pneumonectomy, or lymphadenectomy. If N1, N3, there is obligation of biopsy either by mediastinoscopy or endobronchial ultrasound. Staging of lung cancer. TNM staging. T for tumor. Classification according to size, bronchus of origin, and structures affected. T1 is a size of 0 to 3 centimeters. The bronchus of origin is the segmental bronchus and has no affected structures. T2A has a size of 3 to 4 centimeters. T2B a size of 4 to 5 centimeters. The bronchus of origin in T2 is the principal bronchus. There is the possibility of appearance of atelectasias. The affected structures can be the visceral pleura. T3 has a size of 5 to 7 centimeters. The bronchus of origin is the same. It can be either of them. And the affected structures can be the parietal pleura, thoracic wall, phrenic nerve, parietal pericardium, or it can have nodules in the same lung and lobule. T4 is a size of more than 7 centimeters. The bronchus of origin can be the carina or the trachea. The affected structures include viscera like esophagus, heart, big vessels, diaphragm, or vertebrae. And there can be also other affected structures like recurrent nerve, visceral pericardium, or nodules in the same lung but different lobe. Notes. N0 means that there are no lymphadenopathies. If you can see in the picture, N1 is hilar or lower ipsilateral lymphadenopathies. N2 means subcarinal or mediastinic ipsilateral lymphadenopathies. These are paratracheal. N3 means contralateral lymphadenopathies and also extrathoracic. Metastasis. M0 means no metastasis. M1 means it's metastatic. M1A means intrathoracic metastasis with malignant pleural effusion, pleural implants, or metastasis in contralateral lung, also pericardial effusion. N1B means extrathoracic metastasis, so metastasis in other organs outside of the thoracic cavity. M1C more than one extrathoracic metastasis. Stage. Look at the table. The staging is done due to TNM staging. Depending on the stage, it will have different therapies. Treatment of non-small cell lung cancer. In the treatment of all stages, smoking cessation should be encouraged. If we find a carcinoma in situ, we can opt for conservative resection or the administration of intravenous hematoporphyrin. Stages 1 and 2 are stages which are candidates for surgery with curative intent. The extent of resection will depend on the location of the tumor, with lobectomy being the most common. Both broader resections, bilobectomy, pneumonectomy, and more conservative resections, like segmentectomy, are possible. If the patient is inoperable, radiofrequency ablation or cryoablation, preferable in small tumors, or ablative radiotherapy, preferable in large tumors, can be used. In this group of tumors, the main thing is surgery, but in certain stages, chemotherapy with combined regimes with platinum will be necessary. Stage 1, surgery without chemotherapy. In stage 1A, CT is contraindicated. It means chemotherapy. In stage 1B, the addition of chemotherapy should be considered in selected patients. Stage 2, surgery and postoperative adjuvant chemotherapy, which has been shown to improve survival. There are selected cases in which isolated surgery is performed. Stage 3. Stage 3 is a very heterogeneous group in which resectable and potentially resectable and unresectable stages must be differentiated. To facilitate the study, we divide them as follows. Stage 3A, T3N1 and T4N0 or 1. These are resectable. Surgery plus adjuvant chemotherapy is given. Chemotherapy improves the chances of complete remission and increases the survival. It is usually administered after surgery, although some centers use neoadjuvant induction regimes. In any case, it is established as a rule that neoadjuvant chemotherapy should not delay surgery. Stage 3A, T4 due to local invasion and unresectable. T4 tumors with mediastinal, vertebral, recurrent or diaphragmatic invasions are unresectable with curative intent. The treatment will be palliative. Its treatment is based on chemotherapy and radiotherapy. The degree of visceral involvement must be assessed, which will define resectability or not depending on the affected organs. If resection is possible, surgery will be performed with palliative intent. Carina resection is performed only in very selected cases because it entails high perioperative mortality, as well as a notable morbidity, such as pneumonia, bronchopleural fistulas, vessel rupture, empyema, and stump insufficiency. Stage 3A with T1 or 2 and N2, given the mediastinal extension, neoadjuvant chemotherapy should be administered, and the response to it subsequently evaluated, rescuing those with a good response to chemotherapy for surgery with radical intent. Stage 3B and 3C, these are stages that are unresectable. Its treatment is based on chemotherapy and radiotherapy. In these unresectable stages, 3B, 3C, 3C, 3A with N2 that do not respond to chemotherapy and that have not progressed after treatment with platinum-based radiotherapy, combination chemoradiotherapy with platinum-containing regimes improves survival and quality of life, and until recently was the standard in the treatment of advanced non-small cell lung cancer. However, the important advances that have occurred in oncology in recent times, particularly in biological treatments and immunotherapy, are modifying the traditional approach to these and other solid organ neoplasms. Blocking guide mutations with their presence when their presence is demonstrated in the tumor is considered the first-line treatment, given its effectiveness and low toxicity. These treatments, by blocking the oncogenic pathway of the tumor, manage to stop its progression for a variable time. Although they do not cure the disease, they significantly delay its course and do not prevent the rest of the therapies from being sequenced later when the tumor progression occurs. For all these reasons, they are initially preferred in those cases in which it is possible to use them, which currently represents around 20% of the total non-small cell lung cancers. There is systemic treatment for 3B, 3C, 4A, and 4B. The majority of patients that benefit from this are those with adenocarcinomas, about 20 to 30%. The targets include mutations like EGFR, erlotinib, gefitinib, and ALK, crizotinib, alectinib, which have major penetration in the CNS. Ligand proteins like PD-L1 inhibitors, pembrolizumab, nivolumab, atezolizumab, alone more than 50% of cells express PD-L1. If 1 to 50% use pembrolizumab and chemotherapy. If less than 1%, then chemotherapy alone. Blockade of the PD-1-PD-L1 axis is used with monoclonal antibodies directed against PD-1 of the lymphocyte membrane and against PD-L1 of the tumor cells. It is believed that when lymphocyte PD-1 receptor recognizes the PD-L1 ligands of tumor cells, an inhibitory response is triggered that cancels the immune response, thus allowing the tumor to escape immune control. By blocking this PD-1-PD-L1 axis, it is possible to prevent immune escape from the tumor, activating the immune response against cancer. This strategy is achieving astonishing clinical results, practically doubling the time of tumor progression and the overall survival of these patients with less toxicity than classic chemotherapy, but also a whole new spectrum of new immune-mediated side effects like pneumonitis, myopericarditis, inflammatory colitis, hypophysitis, adrenalitis, etc. Additionally, and due to the rapid evolution of targeted therapies, it is recommended to study the BRAF, MET, KRAS, HER2, and RET genes. The third line is chemotherapy. Although anti-angiogenics like bevacizumab, an anti-vascular endothelial growth factor monoclonal antibody, can be considered in non-squamous cell carcinoma without guide mutations, with a low rate of PD-L1 added to classic chemotherapy or combined with erlotinib in patients with an EGFR mutation. It has much less clinical benefit than the previous ones and a high risk of bleeding. For small cell lung cancer, the treatment is different, usually palliative since almost all of them have metastasis in the time of diagnosis. Small cell carcinoma is a systemic disease by natural history. For this reason, the basis of treatment is chemoradiotherapy, both in limited and extended disease. It is a cancer that is very chemosensitive. Localized small cell lung cancer. In most cases, the treatment of choice is chemotherapy and adjuvant radiotherapy, that is simultaneous administration of radiotherapy with the first cycles of chemotherapy en bloc on the tumor and affected lymph nodes. If remission is observed with the treatment, prophylactic holocranial radiotherapy should be performed. In some exceptional cases in which the tumor is diagnosed very early, equivalent to TNM stage 1, surgery and subsequent chemotherapy can be applied. If, upon removing the mediastinal lymph nodes during the intervention, malignancy is detected in any of them, radiotherapy will be added. Disseminated disease, N3M1 with contralateral lymphadenopathies. The treatment of choice is chemotherapy with palliative intent, combined regimes of platinum and etoposide, associated with supportive treatment. If remission is observed, prophylactic holocranial radiotherapy should also be performed. Operability criteria. Prior to surgery, we should evaluate operability criteria. The operability criteria define the patient's risk of perioperative mortality, not the functional tolerance after surgery. Thus, operability depends on patient's characteristics. There are general, cardiological, and pulmonological inoperability criteria. The main operability criterion is based on FEV1. General criteria. This refers to serious and uncontrollable associated diseases. Poor clinical condition. It means a Karnofsky's index less or equal to 40%. Cardiological criteria. This includes AMI in the previous 3 months. Uncontrollable ventricular arrhythmia is considered too. Pulmonological criteria. The priority is FEV1. FEV1 more than 2000 milliliters or more than 80% of the theoretical is considered an operable patient. FEV1 less than 2000 milliliters or less than 80% of theoretical should be referred to calculate the predicted postoperative FEV1 using a perfusion scan. Predicted postoperative FEV1 more than 1000 milliliters or more than 40% means an operable patient. Predicted postoperative FEV1 less than 800 milliliters or less than 30% means a non-operable patient. Postoperative FEV1 predicted between 30 to 40%, we should evaluate other criteria like oxygen consumption, diffusion, etc. Other pneumological criteria of inoperability include DLCO less than 60% of theoretical, vital capacity less than 45% of the theoretical, irreversible, PaCO2 more than 45 millimeters of mercury, irreversible, severe pulmonary hypertension, and stress test with maximum oxygen consumption less than 15 milliliters per kilo per minute. Prognosis. Lung cancer is the leading cause of cancer death. The strain with the worst prognosis is the small cell type due to its rapid ability to metastasize. 5-year survival in localized stages is 31%, while in extended stages it does not exceed 2%. For the rest of tumors, the size of the tumor primarily influences survival in stage 1, while the number of affected lymph nodes, N1, is the most important prognostic factor in stage 2. Survival at 5 years ranges from 50% in stages 1A to only 1% in stages 4. Thank you very much for your attention, and if you have any questions, please write them on the comments. Like and subscribe to the channel. Goodbye.